So Abiomi, could you introduce yourself and then pass over to Alex?
I'm Abayomi by name. I'm a program officer working in the governance team. I'm part of the presenter for today's presentation. I'll pass over to Alex.
Thank you. Afternoon, everyone. My name is Alex Quarry-Jones. I'm a senior program officer in the governance team at Birmingham City Council Public Health.
Great, thanks, Alex. And I'm Aidan Hall, and I lead the governance team here in public health at Birmingham City Council. So, yes, today, as I've talked about previously, we're going to be sharing some of our emerging insights from the Director of Public Health Annual Report 2024, which is on exploring the impact of demographic change. I think just to make it very clear, we are currently writing this report, so this is just to share where we are at the moment, and as I said, some of those emerging findings and themes. So what we're going to cover today, we're going to talk a bit about what the Director of Public Health Annual Report is, what its purpose is, some background on the census and ethnicity, how Birmingham is changing, why this matters, a bit on intersectionality and the wider determinants of health, and then, as I said before, talk a bit about what some of those emerging themes are. So I'll pass over to Alex, who's going to talk a bit more about what the Director of Public Health report is.
Thanks, Aidan. So if you could just go to the next slide, please. So the Director of Public Health Annual Report, or as we'll probably be referring to it through this presentation as the DPH Annual Report, or DPH Report. It's an annually produced statutory document, which our team produces in coordination with the Director of Public Health, and they are reports on the health of the local community. Now, these can either be kind of general year in reviews, or they can focus on a more specific topic. The approach we've taken has been the latter in more recent years, and you can see there some of the examples of previous reports that we've done on the role of digital technology in public health, how the built environment can impact upon health, and probably most pressingly from the past few years, the impact that COVID-19 had on Birmingham and the population. Next slide, please. So this year's annual report, we've been focusing on how demographic change can affect health and well-being. We've primarily done this by using the wealth of data that we've got from Census 2021, alongside some auxiliary sources as well. And the focus really is to see what significant changes have occurred between 2011 and 2021, and how these might affect health and well-being both now and going into the future. And we're exploring this through 6 different topics: age, ethnicity, sexual orientation and gender identity, migration, housing and employment. And obviously, predominantly today, we will be discussing ethnicity as it relates to the general theme of these webinars through the month. Next slide, please. So here as well, you can just see something that we're currently in the process of, which is commissioned qualitative research. So we currently have a research provider who is conducting research for us out in fieldwork currently with Birmingham's residents to understand perspectives and insights relating to the demographic change, but also what those impacts on health and wellbeing might be. And you can just see below in that pink box there an extract of the participant sample that we've been looking for, particularly relating to the ethnicity topic. And hopefully that shows the kind of diversity and the range of input that we're looking for from different residents. So now, really quickly, just a bit of context on how ethnicity relates to the census and kind of how it can be reported on, which is useful for understanding, therefore, how we can present certain statistics and how these questions have been answered by residents. So censuses in this country and surveys through the 1960s, 70s and 80s didn't have any kind of direct question on ethnicity. They either used proxy questions or estimates, which obviously was not the most accurate way of recording ethnicity. And then the 1991 census was the first to ask a proper question with 7 set answers and 2 free text options. You can see in that box on the right the answers for that by percentage proportion. These questions were further refined in 2001, 2011 with those censuses to make sure that both broad and specific ethnic groups were recorded. And then finally, in arguably the most inclusive census, the 2021 census, that had 19 set answers and multiple free text options. We'll explore later on what the how that kind of allowed for a greater expression of identity when it comes to ethnicity. Next slide, please. Thanks. And then just quickly, obviously, as well to understand is that Birmingham's been affected by multiple phases of migration over the past 200 years or so. And this obviously has helped to diversify the ethnic makeup of the city. So just to give some contextual background to those, there was historic immigration to Birmingham in the 19th century, predominantly from Ireland, but also parts from the Jewish diaspora. Then in the 1950s and 60s, there was immigration from Commonwealth countries. So you can see an example there with those flags: Jamaica, India, Pakistan, Bangladesh. And then fast forwarding slightly to the 1990s, slightly different reasons for migration, fleeing conflict and crisis. Some of those countries there: Somalia, Iraq, former parts of Yugoslavia. And then finally, in the 2000s, there was EU expansion, particularly into or with Central and Eastern European countries, and that allowed for further migration there. So now we're just going to start looking at the actual data from Census 2021. And we're just going to kickstart by looking at the broad ethnic groups here and how that has changed between 2011 and 2021. So we can see now, and the headline on the screen there, Birmingham is a super diverse city. That means that there is no one ethnic group that makes up more than 50% of the population. So you can see that the particular broad kind of ethnic group that we'll be discussing today, which is Black African Caribbean and Black British, there's been an increase of 2 percentage points over the 10 years, although we will be digging into that a bit deeper to understand how those changes have occurred more within kind of the specific groups as much as the broad group itself. Next slide, please, Aidan. So actually, just on that, you can see this is the same change in the same kind of time period from 2011 to 2021, but with those specific ethnic groups instead. And you can see roughly in the middle there, the 3 specific groups that make up the broader group. And you can see that actually 2 of them have experienced a decrease since 2011. But because the specific group African has increased by so much, that on aggregate shows an increase when we look at the broad statistics. Next slide, please, as well. Thank you. So following on from that, you can also see that this chart shows the different percentage breakdown of the proportions of those specific groups within the broader group, and in 2001, 2011, and 2021. And it's interesting to note, obviously, that these have changed quite significantly over the past 20 years. So if we take, for example, Black Caribbean, even though there has only been a drop of approximately 3,000 people in the intervening 20 years, you can see that actually the percentage proportion has dropped from 80% to 35% within that broad ethnic group category. Next slide, please. Thanks. And finally, this is a really, really good illustration of just what Census 2021 was allowed to record. So because there was so much free text choice options, that meant that you could record a whole range of different inputs from residents, and it really allowed you to get very specific ethnic identities expressed. As a result of that, as you can see, 287 ethnic groups were recorded as being in Birmingham. And you can just see on the left there, with the English, Welsh, Scottish, Northern Irish and British as a kind of comparator, you can see the numbers related to those who are presenting or recording that their ethnic identity is within one of those more kind of specific groups. Thank you, Aidan.
So we've talked a lot about how Birmingham has changed, between, over the years, but then from 2011 mainly to 2021. But I suppose what we want to think about in this report, as we are writing it and as we produce it, and what we want people who read it to think about, is what about the future? So we know Birmingham is changing, but actually what happens if we look to the future? So what we've done here is a very simple chart, which basically shows what happens if you just basically draw a straight line. So if you forecast in a completely linear way and don't account for anything else, that broad group of Black African, Caribbean and Black British looks like it will go up to about 13.6% as a proportion of the population. As we know, there are differences within that group that are captured in the census. So I've just showed the difference between African and Caribbean and in terms of geography. So this obviously doesn't take account of that and how those groups are changing, but there's also lots more that isn't in the census. So our colleagues in public health that are more focused on the data, so they're our population health management team, built this sort of in-house model, and they've taken what we've done a lot further. So taking that linear forecast and adding things like fertility rate and mortality rate, and what they found is when they looked at this broad group again, a much more modest increase in terms of that broad group from 11% to 11.4%. But what they did show is that Birmingham will, become increasingly diverse as it has been doing for the last few years, and that is likely to continue. I suppose the point of showing these possible futures is to show that Birmingham has changed and will continue to change. It's not an all-seeing, all-knowing future. These are just different possibilities, and there are a number of factors at play here. So a bit more about that in terms of, we're talking a lot about the census data, but why is this important? Why are we focusing this year's DPH report on this topic? Well, a key part to improving and protecting health, which is a key part of what we do, is understanding our population. So as Birmingham changes, the health needs of that population also change. We also know that the size and makeup of a population can impact both the needs of the population, but also services. So things like health services can be impacted by that as well. It's also essential to understand our populations in order to reduce health inequalities, and this is central to everything we do in Birmingham Public Health. Health inequalities are avoidable, unfair and systematic differences in health between different groups of people. So to tackle that, you need to understand those different groups of people and understand those differences. And just to kind of highlight for those that might not have seen this before, this is over 30 years old now, but it's a model looking at the determinants of health, and it's known as the rainbow model, and it just describes right the way from age, ethnicity, through individual lifestyle factors, social and community networks, living and working conditions, and then the general socioeconomic, cultural and environmental conditions that impact someone's health. And we'll talk a bit about those and give you an example of why that's really important. And then also just to show why these determinants of health are important, and why we really need to understand different communities. This is a train map showing the life expectancy of males and females by station in Birmingham. It's using data before that was kind of around before the COVID-19 pandemic. So kind of building on the maps that I showed of Birmingham, where people live alongside lots of other factors that are described in that model, can really affect someone's life and in particular their life expectancy. So a male in Soho has an average life expectancy, or did when this data came out, of around 75. And in some parts of Birmingham, this is around sort of 83. You see in sort of North Birmingham it gets up to 84 as well. Sort of, he's talking about 8 years difference there, so it's really important kind of that we understand it and try and tackle some of this. So now I'm just going to really quickly move on to 3 different aspects of why this is important, why we're trying to understand it, and what data we are using to try and understand it. So I'm going to talk a bit about the census, then about the pandemic that I've just mentioned, and then sort of touch on a national study on that's done in this particular area. So first, we've been talking a lot about the census. There's actually a question in the census that asks people, it's there, you can see at the bottom left, how is your health in general? You might remember sort of filling that out a couple of years ago. Quite interesting, because you can look at this by not just the broad groups, but those other groups around the African group, the Caribbean group, and the other Black group, and you can compare that to all of the other slightly more detailed groups. And as you can see there, the group with the highest levels that answered very good or good health according to them was the African group. And nearer the bottom, you can see some of the other groups that we're sort of touching on today, so Caribbean, other Black, and then you can compare that with the broad white group as well. And I'd be actually quite interested to learn a bit more about why this might have been. And it's just one question on one day, but I still think it's quite interesting. The second example to talk about why this matters is COVID-19. Obviously, people will probably be aware of the stark inequalities that were both highlighted and exacerbated during the pandemic. I'm not going to go through these, but they're just for people if they want to go and read them. Obviously, the inequalities were felt across different communities, but particularly by ethnicity. So the top two look at death rates and compared those. They look at mortality rates. The third one looks at sort of various different factors and how that impacted ethnic inequalities, so the prevalence of long-term conditions or low self-confidence in managing their own health. And then the final one, actually at the bottom, looks more at some of those wider determinants, so someone's occupation and employment, and actually how people were put at risk potentially by the type of occupation they had. And then, just to finish off with, it kind of builds on this one a little bit in terms of, inequalities in this area are quite complex. Well, not quite complex, they are. And also why looking at just the kind of very broad groups doesn't tell you the full picture. So these are just two studies. They are at a national level, but we can sort of compare them to what also goes on locally as well. And I think we are sort of looking into doing this at a local level. But these are two examples that show differences between sort of ethnic minority and white British groups, and also between different groups as well across a number of different health conditions. So the one on the left looks at mortality, so death, and the one on the right looks at morbidity, which is disease. So I'm just going to go through the one on the left, which is from the Office of National Statistics, and the one on the right people can go in and sort of read if you want to, and that one's from the Health Foundation. So if I just look at the ONS study and why it's really important to understand our populations and using the census. So this was inequalities in mortality, so death, looking at common physical health conditions. And basically what this data shows is that people from ethnic minority groups, including Black African, had a lower overall mortality than the white British group. And the way they can kind of work this out and calculate this is using the census data and linking the census data to death registration data, because someone's ethnicity is not actually recorded on the death certificate. The other thing they do, which is really important, and I just noticed it on the slide there, is they use age standardized mortality rates, and these are used to compare populations that contain different proportions of ages. So if one population has a lot of older adults, it's very difficult to compare to another ethnic group that doesn't. And as that slide shows, the white British group had higher mortality than other groups, but there are also lots of differences between the groups. So if we sort of take a couple that we've talked about today, the Black Caribbean group, but then also the Black African group, you can see differences between those as well. And it just emphasizes looking at those groups in more detail, notwithstanding the fact that it's not perfect and there'll be lots of differences within these groups as well. In terms of the reasons for this, we do explore these in the report. So I would really encourage people, once we've kind of finished it, to be involved as we get through to the final stages of it. One of the things that we talk about is something known as the healthy migrant effect, and that people moving to Birmingham, for work or study reasons, may be slightly healthier, in some cases than the people that have lived here for a long time. And there are lots of different sort of factors in there as well, but just that we do go into that in the report in a bit more detail, so I'm not going to now. And just to kind of look at this study again, it goes also, I would really encourage people to go and look at it. It's really, it's really interesting. One of the things that they do is they look at each individual sort of condition, or a number of common physical conditions, I should say. And this is conditions that are noted anywhere on the death certificate. And one of those is heart failure, and you can see there that the sort of white British group, not quite as high as some of our sort of Asian communities, but actually is higher than Black African and Black Caribbean. I think a good example as well on this is the differences between that broad Asian group with Chinese at the bottom and then other communities sort of at the top here. So, but then also in other cases like prostate cancer, we see the reverse. So Black African and Black Caribbean are sort of at the top for this one, and then followed by white British, so they are higher, and then some other communities sort of having a lower sort of rates of mortality. So that's just some examples. So it's a bit of a whistle-stop tour of it. And now I'm going to hand over to Abayomi to talk about intersectionality and the wider determinants.
Thank you, Hayden. Can you move the next slide, please? Yeah, I would like to talk about intersectionality. Intersectionality is actually a term that originated from a feminist scholarship through the work of Kimberly Crenshaw. Is actually a legal scholar who noticed the failure of the anti-discrimination law to recognize the intersection of the effect of racial and gender discrimination. Ever since, the intersectionality has actually grown wider, more than the initial stuff of racial and gender discrimination. Intersectionality describes the way in which oppressive institutions such as racism, that's the discrimination through from the point of race, discrimination through sexism, that's discrimination based on your gender, and this is actually related to more of the female folks. Then we have homophobia, discrimination based on the fact that the person is a gay, transphobia, discrimination towards the people of they are transgender. The ableism, that's discrimination towards people that are disabled. Then we have xenophobia, discrimination towards people that are from a particular origin or the particular country. Then we have classism also as a discrimination towards the group, where a particular group where people belong to in the society. And what intersectionality is talking about is that looking at all these oppressive institutions, how they intersect without looking at them from only one point of angle, making sure that we look at the intersection of the effects these people have on the people and how it produces inequalities within the population. One person or group may have multiple forms of oppression directed against them at the same time. Like a classical example might be maybe from if someone is a woman who is pregnant, is a Black woman who is pregnant, and is actually belongs to the female the Muslim he has the Muslim religion. So if you look at that woman already can actually be discriminated on four grounds, because of she possesses four social identities. Number one, she's Black, she can be discriminated based on that. She's pregnant, based on her reproductive state, she can actually be discriminated on that. And she's a woman, so she can be discriminated based on the fact that she's her gender is a female, and she can also be discriminated because she belongs to the female the Muslim faith. So some people are actually discriminated based on their faith. So what intersectionality is saying is that don't look at the discrimination from the gender point, don't look at the discrimination from the religion point, don't look at the discrimination based on our reproductive state, or maybe because of or from the race aspect. Say, look at all the intersection of this effect and how it produces inequality and how it widens the inequality among different people within the population. Next slide, please. And this is an intersectionality way where it can also be used to describe intersectionality. And we can look at the outer layer where we have the transphobia, colonialism, homophobia, ageism, racism, classism, religious discrimination, and all that, and where all the different identities within here are actually intersected. So that's just a lens. Intersectional is a lens through which we can actually observe how these things intersect to affect people and produce the kind of experience that people are experiencing within the society. Next slide, please. Now, why is intersectionality important to us in public health? Because it is seen as a promising approach to the analysis of power structures and processes that produce and sustain health inequality. As a public health person, our major priority is to reduce the inequality gap within the population. So when we look at things through the gender, through the lens of intersectionality, it will actually help us to deploy strategies that can help us to address all the inequality gap. Intersectionality moves beyond examining individual factors such as biology, socioeconomic status, sex, gender, race. It instead focuses on relationships and interaction between these factors across different levels within the society and how these things shape shape across population groups and geographic contexts, meaning that how these things in combination actually affect people. So intersectionality help us to look at that, how all of them, without looking at one separately, how all of them intersect to produce the effect that we are seeing in the society. And the goal of intersectionality is to map out health inequities with more precision so that we can actually produce more programs, more strategies to address this issue. Next slide, please. Now, looking at intersectionality from the DPH report lens, we are actually looking at, we have age, sexual orientation and gender identity, we have faith, we have migration, we have disability. So this, as it has been said earlier, that we are looking at intersection, we are looking at Black History Month through the lens of the DPH report. So here we have some charts to display some of the things that we are talking about, like intersectionality, and here we actually shows age. And the next slide will actually take us to how age within the different ethnic groups happens within Birmingham. So here we are talking about ethnic groups have different age profiles within Birmingham. When we look at it, we can see it, because we're actually talking about ethnicity, especially the Black History Month. So we actually highlighted more of the Black histories here. So we can see that Black, British, Black, Welsh, Caribbean, African, other African, we can look at their different age profile here and also compare with other areas. So looking at ethnic groups, we realize that they all have different age profile within the same population here in Birmingham. Next slide, please. Thank you. Now we want to talk about the wider determinant of health. We already look at the intersectionality, how that can actually produce unequal health outcomes that we see within the population. We want to also talk about wider determinant of health. It's not only about the intersectionality that can produce health inequalities, we also have wider determinant of health, and we're going to look at it through the DPH report. And this, as Aiden has said earlier, this is the diagram model of health. We also call it rainbow model or the socioeconomic model. All these different layers, individual factors, social and community network, the socioeconomic, all these things act in combination to actually produce health inequalities within a population. And some of them can actually act alone, because there's, for example, when we look at the individual factors, we have the age, we have the sex. There are some specific diseases that can actually affect someone based on their age or their sex. Then again, all these things can actually act together to also, they are interdependent as well. They can also act together to produce the different unwanted or even health inequality, health outcomes we see within the society. But based on the fact that we are looking at the DPH report, we are going to talk about, we have the housing here as one of the things that wider determinant that can actually affect people's health. We have unemployment. We also have other things, and we're going to look at this slide. For now, we have on this slide, we have some ethnic groups are more likely to own their home outright or with a loan, with mortgage or loan. So looking at these charts here, we can see that the white, English, Welsh, Scottish, Northern Irish, or British, they are more likely to, this ethnic group are more likely to own their house within this within the census report. The census report is what data is what we are using to base our facts on, and we can see that from here they are more likely to own their own house. So looking at this in total, different ethnic groups, we can see that they have their own what's it called? They have their own different their own different denominations, whether owning a house or getting a mortgage through loans or through other means. So some ethnic groups are more likely to own their home outright or with a loan or mortgage. Next slide, please. So here we have the levels of overcrowding vary across the various groups, and this is also from the census data. We actually realize that some groups of our people, different ethnic groups, some are more likely to be overcrowded in a house, whereas some are ideally occupied, whereas some people in some houses, there are more rooms than the people that are living there. So we have the occupancy rating per bedroom. Those that have the occupancy rating with less than 1 or -1 means that the house is actually overcrowded. And if you look at it critically on this map, on this chart, we can see that the blacks or the Africans, they are more likely to live in an overcrowded situation, and this could also affect the health of the people as well. Then we have the black, and looking at the whole chart in general, we can see that some people, they occupy in the rooms they are occupying is ideally living in an occupied area, whereas some people are overcrowded, whereas in some areas there are less people living in the house. Next slide. Thank you. Now I'll hand over to Alice to continue. Thank you.
Thanks, Abiyomi. Just going to touch on now some of the emerging themes that we've got in the report, and I'll just reiterate what Aidan said earlier. We're currently in the process of delivering and developing it. So some of these are potentially subject to change, but this is what we've come out with so far. And obviously they will also be informed by that qualitative research that, as we said, is currently out in the field. I won't go through all of these, but I think the two that I really want to highlight are those two on the right-hand side, and that we've definitely touched on them in this presentation as well. So the first one around accurate reporting of specific ethnic groups in health data. The census has been really useful just for us for the purposes of this, because it has provided such a granular level of data, both for all of the different kind of characteristics, and in particular for ethnicity, those specific ethnic groups, but also just then allowing us to compare that in a multivariate way with other factors such as age, housing, as Abiyomi was just touching on. And obviously one of the things that then needs to follow through is to ensure that we can get that reported in health data, so we can understand where there are inequalities in health outcomes as well. Related to that is the use of an intersectional approach when developing our solutions and programs for tackling health inequality. Again, obviously Abiyomi touched on that quite comprehensively, so I won't necessarily go over it, but the point being that we must understand multiple identities are always impacting upon someone's situation, and therefore we must approach that from that intersectional angle rather than trying to look exclusively at one of their identities. Next slide, please, Aidan. So we're very much coming to the end of this now, so whether that's positive or not to those who are watching, but just a quick summary of what we've covered. So we've obviously had hopefully a quick introduction to those three key areas: the DPH annual report itself, the census, which we've been using as our body of evidence for this report, and just on how ethnicity has been reported in the census and sometimes reported in other sources as well. Some background on how Birmingham has changed using that census data, and hopefully that's been illustrated convincingly for you. But some more detail on the reasons why the changes in Birmingham's population have been significant for health and wellbeing, and obviously how those then do come on to affect and impose health inequalities, how our identities can intersect and then amplify health inequalities, and therefore the need to treat that with an intersectional approach, and then some of those emerging themes that we've got. But I would strongly recommend that if you are very interested in this, that our next steps are at the bottom of that slide, and in particular, we will be producing the final report for publication in March next year. Next slide, please, Aidan. So these slides will be shared out, so hopefully you'll be able to access all of the links and anything that we've put in, but these in particular are extremely useful to use, and two that I would recommend if you are more interested in this subject or want to get your hands on the data in a kind of really compatible and easy to visualize manner. That's the Birmingham Census Dashboard, available via the Birmingham City Observatory, and Census Maps, which is a website created by the Office of National Statistics. Really good way of visualizing that data, especially the census maps for the geographic areas. You can use the entirety of England and Wales, but obviously if you want to explore Birmingham, and in terms of that granularity, you can go really, really far down into particular geographic areas. Very useful to understand, and also see those changes from 2011 as well. Next slide, please, Aidan. And finally, as well, if you do, I think you may be able to access this through the presentation. If we have that enabled, you can use this link. Otherwise, you can use it on the slides when those are sent out. Please do provide us with some feedback as to this presentation. We'd like to know what went well, what maybe could be improved, and any thoughts as well on the general topic of the Director of Public Health annual report as well. And next slide, please, Aidan. Yeah, so now we're opening up to any questions. I'll just have a look if there are any in the chat. Well, we have a helpful comment from Monica, who has said that the Dahlgren and Whitehead's model has actually been updated now. So it's a bit more comprehensive, including some of the factors that we've talked about today. So that might be useful for those who are looking to use that. There aren't any more questions in the chat unless anyone wants to put any in otherwise, or we've got some time. I think we could always open up to questions on the floor. Does anyone have any questions?
I think questions or reflections, to be honest. Anything that jumps out at you, anything that you think we have missed or we should explore. Obviously there's so much to the census data. I think I'm just going to stop the recording and then if people want to come